There we go. All right. So this is on benzodiazepine use disorder. Well, primarily benzodiazepines. If we're using the DSM nomenclature, it's SHALD, sedative hypnotic anxiolytic use disorder. For most of us in most situations, that is going to be benzodiazepines. Neither Justin nor I have any disclosures to make today. So here's a little bit of an outline what we're going to be going over. And so just a little bit of terminology on at the onset is when we're talking about sedatives, hypnotics, and anxiolytics, these are sort of the general effects that we would see with any of them. In general, anything that's under one of these categories typically is going to have some effect similar to the rest of them as well. But when we're looking at primary effects, sedative is calming in the sense of body processes, not calming in the sense of anxiolytic. That is more what the anxiolytics are for. But the sedatives can have a calming effect in terms of body processes for respiration, things of that nature. Hypnotics are primarily used for sleep, and anxiolytics' primary purpose is to reduce anxiety. Again, as noted, there's a lot of overlap between the categories here. And so anytime we see one medication that's in one of these classes, there's typically going to be some of the other effects as well. And we do with all of these have this sort of continuum of effects. The therapeutic window for most of these is relatively narrow. So we can see, we'll see the calming aspects. They can cause sleep, but then they can cause too much sleep, leading to unconsciousness, coma, and death, particularly in conjunction with other substances, as we'll see here in a bit. So here's a quick list. I won't read all of these, but just the Z drugs here. Those are primarily our sedatives. And then benzodiazepines, primarily what we're going to be dealing with today. Barbiturates, which we do not see quite as often as we did in years gone by, but they are still out there. We still use them acutely for various medical conditions, including in withdrawal states. And then, let's see. So, I will confess, this is most of what I know about the history of sedatives is on this slide. So 1864 is when barbituric acid, so when we think of our barbiturates, right, that is the initial discovery. Barbitol synthesized there in 1903. It actually did have a pretty significant role in primarily in World War II. Barbiturates were given to soldiers in pretty significant amounts following their stimulant use. So if you can imagine the need to be awake and alert for days at a time for troop movement, things like that, they would be given stimulants to stay awake and alert. And then barbiturates were given to calm the, primarily as an anxiolytic to the soldiers during that time. Librium in 1955, the chlordiazepoxide was our first synthesized benzodiazepine. And then in the 1960s was really when those started to hit the market. Valium was marketed and introduced first in 1963, and then 1981 was kind of our banner year when Xanax first came on the market. And all of these are barbiturates, and our benzodiazepines are still in use. Again, benzodiazepines more so than barbiturates now, but there's still a role for barbiturates in acute management. So similar to other use disorders, benzodiazepines, they have 11 different criteria in the DSM-5, and similar to the other use disorders, they can very generally be categorized into physical dependence, which we see down here in our last two, tolerance and withdrawal. And then we see the loss of control, which is things like important activities given up and reduced, time spent to obtain, use, and recover. And then we see use despite consequences, things like failure to fulfill major role obligations, recurrent use in hazardous situations, or continued use despite physical, psychological problems. So those are sort of hallmarks of our substance use disorders are tolerance, loss of control, and use despite consequences. And benzodiazepines and the other sedative hypnotics and anxiolytics fall under that category. As with our other use disorders, mild is 2 to 3 criteria, moderate is 4 to 5, 6 or more qualifies for severe use disorder. Above and beyond many of the other reasons why we are concerned about these disorders, there is significant healthcare and societal cost associated with these use disorders. But again, our primary concern is that of human life. And so as we see here, benzodiazepines by themselves, and I do not be deceived by this very slight downtrend in the past several years. All of these are still on the rise. And the more recent data from, well, I guess peri-pandemic and post-pandemic, if we are feeling confident enough to call ourselves post-pandemic yet, these are trending back upwards. So that most recent data is a bit deceptive. But the primary teaching point here is that when we are combining substances, our risk of overdose goes up. And that's something that intrinsically makes sense to us, but opioid tends to have less overdose by themselves than opioids plus benzos. And that tends to have less overdose than benzo plus opioids plus alcohol. So when we are combining substances, whether that is co-prescribing or buying off the street or getting friends and family doses, when we are combining substances, our risk for overdose is going to go up significantly. So benzodiazepine intoxication looks a lot like alcohol intoxication. They're working on that same GABA receptor, and so a lot of the effects that we are going to see are going to be the same. Slurred speech, they can have an unsteady gait, typically a horizontal nystagmus, but they can't have nystagmus, just cognition issues, and then in significant amounts, stupor or coma. Oh gosh. Yes, please. Okay. Oh, okay. So withdrawal symptoms, again, looks very similar to alcohol withdrawal symptoms. And if you think about just as a very broad overview with any kind of use disorders, withdrawal typically is going to look the opposite of what intoxication looks like. That is certainly the case with benzos here, as opposed to sleepiness, stupor, coma, slurred speech, those sorts of things. You see the opposite of that. So we start to have some autonomic hyperactivity. We will see a lot of tremor, psychomotor agitation, anxiety goes way, way up. And then here are some physical exam findings that you may see. The most frequent and easy to spot things that you're going to see are things like the tachycardia, the tremor, the diaphoresis oftentimes. And then similar to alcohol withdrawal, with significant benzo withdrawal, you can have seizures, delirium, and death. So in managing benzodiazepine use disorder, one thing that we like to look at is what is their equivalent doses, because a lot of times when you have patients who are coming in and they've been getting their medication off the street or from friends and family, a lot of times it's not a consistent dose. It's not even a consistent medication typically. And so having at least a rough idea of equivalent doses, there is a little bit of uncertainty in terms of, when we have these 5 to 10 milligrams of diazepam, well, is it 5 or is it 10? Because 10 is twice as much as 5. And so having an idea of the equivalency is helpful, but this is helpful in getting in that ballpark because diazepam typically is going to be one of our go-tos when we start talking about tapering. So getting away from the shorter acting medications like Xanax and the Ativan, and then getting on something like diazepam that, in addition to being long acting, also has long acting active metabolites, which can help with some of that withdrawal severity as we get down to the lower doses. Here are some pictures of some benzos. A lot of different names for them depending on what it is. You hear the totem poles and the footballs, and interestingly enough, the people who are pressing pills and selling whatever it is they're selling that's laced with fentanyl now, they don't just make pills in circles. They can make a lot of these other ones too. So I have had patients who say, "Oh yeah, I know what I'm getting," because it's the little football. Well, maybe not, but these are some of the more, I guess, typical or well-known formulations. So when we're looking at testing for benzodiazepines, similar to our other substances, we can either do a qualitative or a quantitative. Qualitative test is just an antibody test. It is a yes or no, is the substance detected? And the benefit of that is it's cheaper, it's faster. And so when we're having discussions with patients about their substance use, it's very, very helpful to have that result in front of you before you have the conversation. And a lot of times, we can kind of stop the testing there at the qualitative, depending on how our interaction with the patient goes. So, hey, your urine was positive for benzodiazepines today. Is that something that you've done recently? Do you know where that would come from? And a lot of times they'll say, yes, I was stressed out a few days ago. I got a Valium from a friend and I took that. Okay, well, at that point, their drug screen is consistent with their history, and very likely there's not a need for a quantitative test there. Quantitative test is helpful when the history and the discrete data are not lining up. And a lot of times we do have false positives with that qualitative antibody testing. False positives with benzodiazepines are one of the more common ones, not quite as common as, say, with amphetamines, but more common than things like opioids and cocaine. So anytime there's a discrepancy between the data and the patient's story, then it can be helpful to send out a quantitative, and that is via GCMS, which is gas chromatography mass spectrometry. And so this is, as the name implies, it's quantitative. We can get levels. It tells us for sure, because it's not just looking for general shapes of the molecules, which is what the antibody testing does. It looks for very specific molecules. So we get better information there. So some of our limitations, again, a positive benzodiazepine test on the qualitative, which is typically the point of care testing, doesn't necessarily mean that it's there. And then just because it doesn't show up doesn't mean it's not there. Klonopin or clonazepam is a classic example of this that is typically not going to show up on the point of care testing. And so we will oftentimes send off for a quantitative test on that. And then the downsides to the quantitative testing primarily are time and money. You're not going to have those results at the time that you're talking with the patient, and it does cost more. So again, that's why we'll typically reserve this for if there's any sort of question regarding the results. So we do see this from time to time. This is just oh man, I need a little picture here for clinical pearl, because this is just a little clinical pearl. If you do have a patient who is telling you like, yeah, I had, I just want to be honest with you, I got stressed out, got a totem pole, took it yesterday, and their benzos are negative. Yes, send it for confirmation. But as I said a few slides ago, always thinking about fentanyl and or any number of things that could be in with those, because the pill presses don't just come out in circles anymore. So this is similar to alcohol use disorder, and primarily alcohol use disorder. It's similar as well to opioid and stimulants. The big difference between alcohol and sedative hypnotic withdrawal versus amphetamine and opioid withdrawal is that alcohol and sedatives can be acutely lethal to withdraw from, which is not the case with opioids and amphetamines. And so we do have to have a higher suspicion for people needing a higher level of care. So if there is no sign of intoxication or withdrawal, then likely they're appropriate for outpatient treatment. Now, there is also the ASAM criteria that if you go through their 6 dimensions of someone's care and support system and medical comorbidities and psychiatric comorbidities and all of that. So it may be that someone doesn't have signs of intoxication or withdrawal, but they have no support system. They have significant medical and psychiatric comorbidities, and they have a history of significant withdrawal with seizures or something like that. Even in the absence of intoxication or withdrawal, if they're on something that's a little bit longer acting, they may still be appropriate for a higher level of care. But typically, they'll be appropriate for outpatient if there is no acute intoxication or withdrawal. So in early withdrawal, there is an option of inpatient versus outpatient. The CWAS scoring is not as validated for sedative hypnotic as opposed to alcohol, but that can actually still be a very helpful tool to use in determining what level of care someone is appropriate for. And then at any point, if there are severe withdrawal symptoms, and or again, if someone has a history of withdrawal seizures, withdrawal delirium, having to be hospitalized because of withdrawal before, that's when they would be appropriate for medically managed inpatient. And then we will use flumazenil at times in the acute setting for overdose. Outpatient management, which is primarily what we're doing here. So the big thing is working with your patient, figuring out what their goals are. And so if they come and they are wanting to completely abstain from benzos, then we work with them on that goal. So we work on the taper, and you need a lot of buy-in from the patient for this. You need to have a good relationship with your patient and the ability to troubleshoot together because there will be bumps in the road. So we'll use intermittent quantitatives. And this is just a general rule of thumb for, well, really for any time that we're prescribing controlled substances, but particularly with benzos, because as noted, if there is clonazepam, that may not show up. And so depending on what agent you're using, so if you were using clonazepam as their longer acting agent to work on the taper, then that may not show up on your point of care qualitative testing. So you may need the quantitative for that. The other reason is even if your benzodiazepines are coming up positive on your point of care, say, for example, if you switch them to Valium, that still, it really doesn't give you any information as to whether or not there are other benzodiazepines that are in the patient's system as well. And so using those quantitatives can be helpful. As a general rule, we want to convert any short-acting medications that they're on to a long-acting, typically either clonazepam or Valium. And that's where those equivalency charts can be helpful, so that someone says, oh yeah, I'm taking a milligram of Xanax and I'm taking 2 or 3 a day. Well, we can look at that and get a rough estimate of what their Valium need is going to be. These percentages here, 15% every 2 weeks, 25% every 4 weeks, depending on how long a patient has been on benzodiazepines and where they are, this is a relatively aggressive outpatient taper. Certainly you could do it much more quickly than this in the inpatient setting. But this is so 25% every 4 weeks. So that is, it's an ambitious goal. It's a good guideline, but always taper is individualized to the patient. And so sometimes patients will come in and you've just decreased their dose and they're feeling great and they want to just roll with this momentum and they go, let's go ahead and cut it again. You go, okay, great, we'll cut it again. And then they come back in a week later and they go, no, this is terrible. Let's hold here for a bit. And so you hold there for a bit. And so it's always individualized to the patient. Again, weeks to months, depending on what other support the patient has, what other coping skills they have to handle the things that pop up when they're tapering their medications. A lot of times in the setting of a medication taper, there are things in life that people think they've dealt with, and then the medicine goes away and they go, oh, no, I never really dealt with that. And so sometimes that's where the taper can slow down a bit as well, as these things crop up. We'll go, okay, well, let's hang out at this dose here, and then let's get more therapy work in, right? Let's do more individual work, do some trauma work on whatever it is that's sort of a roadblock to them and is triggering some of their use. And then we always want to treat their comorbid psychiatric disorders as well. Counseling is far and away the most important thing for them. Counseling structure. The medicine is helpful from the aspect of we're helping to prevent withdrawal, but in terms of having the substances go away, learning new skills, learning other ways to handle life other than just needing external pills, whatever it is, the counseling is the most important piece of that. Inpatient management, again, very similar to alcohol. So we can do it's typically a 3 to 5 day taper. This 5 times daily. So we're looking at, maybe 50 milligrams a day. That's pretty standard for a lot of detox units. And then we can use some adjunct things as well for, you can use things like clonidine or hydroxyzine, prefer clonidine, for anxiety that goes along with it. We can do gabapentin adjunctly. And then if they're having hallucinosis or agitation, we can use adjunct antipsychotics. Although if someone is withdrawing to the point that they're having hallucinosis, a lot of times they're going to be intubated and sedated. And so if we have people that are acutely withdrawing and they are having significant agitation and hallucinations, sure, you can try an antipsychotic, but they're probably more appropriate for ICU care, and they should be sedated at that point. And then outpatient follow-up is very important. Okay, that's all I have.